Ready.
Hello, everyone. Good morning, good afternoon, good evening, and thank you for joining us today. My name is Qaiser Mukhtar, and on behalf of my colleagues from TEFINET and the CDC Division of Global Health Protection, I wish you a happy new year and welcome you to the first NCD Professional Development Series of 2024. We are excited to share a couple of reminders and announcements about the upcoming webinars. Starting with reminders, so as usual, welcome and please introduce yourself in the chat box. Also, be sure to write your questions in the Q&A tab, not in the chat tab, but under the question and answer tabs. We are also adding interactive polls to the webinar, and we encourage you to participate. You'll see the poll right after the lecture. Now to the announcements. We thank you for completing the evaluations and sharing your feedback with us. For the longest time, you have been asking for more time, and you'll be happy to know that we are extending the webinar duration from 1 hour to 1.5 hours. And please continue to share your feedback. It is important to us. Next slide, please. We are thrilled that our favorite faculty from the World Hypertension League will teach 2 series this year. Today, we begin a 6-part research methodology series covering aspects, such as types of studies and risk estimates, bias and confounding, abnormality, risks and assessment, and tools for assessing research study evidence and study quality. You'll notice that a lot of these topics come from the list of suggestions you made. And knowing that most of you attend the entire series, we will offer a certificate of participation for those who attend all 6 sessions. Next slide, please. So without further ado, I invite Professors Lackland and Professor Weber to present today's webinar. Thank you. Over to you, Dan.
Very good. Thank you, Qaiser. Great. And we very much
and my apologies. We also welcome Professor Whelton. Thank you for joining us today. Over to you.
Thank you, Qaiser. And we thank you for the opportunity to be a part of it. Again, I'm so very, very honored to be joined by Professors Weber and Whelton and kind of go through this series that individuals wanted to see, talking today about the types of studies and risk estimates. And as you start to think about your work, how you'd like to display your work and consider the type of work that you would like to move forward, we thought this is a good topic to move forward and things that we can address. So our usual disclaimer that this is the responsibility of our panel and does not represent the official pitch of CDC. Today, what we'll talk about, we will compare case series, cohort studies, and case control studies, describe a little of the interpretation of the measure of the association that we get from a cohort study versus a case control study, and we'll identify potential problems that are in the area that when you conduct an epidemiologic study that might impact the findings and how you might think about what you're trying to present from your critical question. We'd like to start, I think, as we've done before, looking at the evidence pyramid and where the different components are. All of these are ways that we can develop some type of evidence and some type of an assessment, but they have different levels and different strengths as we go through. If we're down at the bottom, oftentimes you do see expert opinion And when you have the opinions of individuals like Professor Whelton, Professor Weber, that has a great deal of value and a great deal of evidence there. But then again, we also think that there's a lot of expert opinions, and a lot of people have those. As we move it up, we go to the case series and case reports that we'll talk about, observational studies. And then at the top, as we move forward, the randomized control trials, randomized and systematic reviews of these of the sophisticated studies. We're going to focus mostly today on the case series and observational and cohort studies. As you think about the studies that we want to do and that level of evidence that you're trying to do, and again, this brings into your critical question: what are you trying to answer, and how do you want to impact practice? Do you want to impact just observations that we'll talk about? And so it's going to be based on what your plan is and that level of evidence that's going to be there. As we've indicated previously with the pyramid, level A evidence is basically consistent randomized controlled trials or cohort studies. And basically you validate the clinical decision rule validated in different types of populations, and you get this level A. If we go to a level B, it's a consistent retrospective cohort studies, exploratory cohorts, sometimes ecological studies have done well, outcomes research. You see this in case control studies, as well as looking at extrapolations from those studies that were done with level A evidence. Case series that we'll speak about first is level C evidence, and basically these are also an important piece. There are levels of evidence, just not at that same level as you would see with the retrospective cohort studies and case control studies. And then again at the bottom, just to keep mentioning there, is that expert opinion. All of these can be written up. They're all evidence, and it's just wanting to make sure that you're working with an appropriate level of evidence. The other piece that you ask is you write your critical question and you're trying to resolve this. What are you really wanting to answer? What types of things that you're seeing? If we're looking at phenomena, we would be looking at observational studies as well as qualitative studies. If you're interested in the etiology, you want to present something with the etiology of a disease or a condition, those are typically done with cohort studies and also case control studies. Just a simple diagnostic or screening, cross-sectional studies, analytical studies work quite well. Prognosis is going to almost require a cohort study as you're being able to follow someone forward. And then the intervention studies we would typically see with the randomized control trials. So asking that critical question, selecting the appropriate study design that you would like to move forward. So let's begin with a case series, and as we look at this, we can pick out a quick case series, and oftentimes these are quite valuable. You see this, a case series, a case report, or a case study basically are descriptive studies that are trying to illustrate something that's novel, unusual, an atypical type of finding, perhaps in patients in a medical care practice or even in the population. This potentially designs kind of new research questions. This is an interesting phenomenon, and what can we see? And I know Drs. Weber and Whelton see this all the time. These are studies that can actually be well published and carried forward. The advantages, one of the pieces, you just need one case to basically have a case report, something that you found to be very interesting, not necessarily routine, something that was unusual, something that was new. It provides stronger evidence. It can be seen with multiple cases. So you found multiple cases of this unusual type of finding. It's observational. It is educational. almost most important, it's easy to do. You can do it very fast, and you really need no financial support to carry this forward. And these oftentimes identify some type of rare manifestation of a disease or some unusual finding that you can carry forward. But very importantly are the disadvantages that you have with the case series. There's no control. You're not being able to compare this with anything, and you're just finding this there. The cases, more often than not, really can't be generalizable because it, again, that kind of rare piece. There's a huge selection bias because you chose it because it was unusual. And it also, you don't know what's going to have the future outcome or the follow-up. It might just be what we would say a one-time observation, interesting, and very, very publishable.
Well, could I ask a question then, as we're going through this? My experience as an editor of a journal, but also in thinking about cases that could be reported, is that in general, journals don't like case reports, and the publishers don't like case reports because they're not often quoted, they're not often cited. And so if you're a journal or responsible for a journal, and you're concerned about your impact factor, you may be reluctant to accept case reports. And because of that, I have noticed, but I haven't gone into it thoroughly, perhaps you have more information about this, there are now one or two journals that are actually titled case reports. Yes. They just devoted to that. And I wonder if you could make a comment about those sorts of journals, because I think they may be providing an important service. At least I hope they are.
Yeah. But Weber, I think it's an excellent piece, and I think there is an opportunity there. So you see something unusual, particularly early career individuals, even lower than that, can find an unusual case, look it up, recognize it hasn't been really reported at any particular level, and now you've got something interesting that could lead to could lead to publishable papers. Is this worth further study? Or kind of get that feedback. Well, we see this really more frequently than is reported, and so I think either way, case reports can be pretty good, and also a single case report can lead into a case series like we have here. I think it's an important decision. To your point, though, I think we're going to move into a couple of published examples of studies that a case series that can be reported. This is in the BMJ Global Health, and this is what they were basically looking at were how different country programs adapted to the pandemic, and how we were getting basically healthcare delivery in different types of settings. And so they did a case study looking at a variety of different series, a very, very simple study done in relatively quickly. And they pretty much in Brazil basically took 11 cases, grouped into 4 family clusters, and came up with the conclusion that with more specific information about risk for different client groups, the targeted approaches can be done to ensure that those at risk of a special threat are having access to sustained services. This is just a very, very simple piece that our individuals at this point during the pandemic were people getting the services in this case in Salvador, Brazil. We all want that to be the case. Very, very simple study that cut into this, that basically you could say that the pandemic in this particular case, for this particular case series, they were suggesting that while COVID is there, you can make adjustments in your delivery system, and they were successful in having that access to care. Another one is probably the more traditional case series. This is just a simple report in BMC nephrology. And this was a case report of a malignant hypertension in a young woman. This is a 33-year-old woman presented with severe hypertension, acute renal failure. She did not undergo renal angiography, but she continued to be medically treated. And in this particular case, one case, after 2 years, they came to the importance of control of blood pressure, again, for kidney function recovery. And this might be something that's here, but in this case, it's just another kind of situation, a finding that's easily put out there. And this particular journal does publish a number of different case reports that we have. So something to consider, depending on if you have something that I think it could be, an important piece. But I think good thoughts with what Dr. Weber is doing is to make sure that if you are writing a case report, that you are going to submit it to a journal that is encouraging for case reports. This is probably the issue, though, with case reports, is you really need that comparison group. You want to say to what? And so if we look at the pieces with cases, the questions that you do want to have, is this reflective of the population at large? Is this just a chance happening? This is where you need this comparison group. Is it related to other unknown factors? Bringing in that comparison group allows you to compare and bring these kinds of findings into perspective, and also doing what Dr. Weber has been suggesting. If we look at some of the concepts, we think about this odds ratio and relative odds, and I know many of you have had this piece. This is just kind of a little simple example. So suppose we're betting on a horse named Beauty, which has a 60% probability of winning the race. Beauty, therefore, has a 40% probability of losing the race, just by simple mathematics. If these are the probabilities, what are the odds that the horse, Beauty, will win the race? And again, the odds of an event are basically divided as the ratio of the number of ways the event can occur to the number of ways that the event cannot occur. Lots of just a little formula there and this kind of stuff, but this gets a little bit simpler. The odds of Beauty winning the race is defined above. The probability that Beauty epidemiology will win the race divided by that the Beauty will lose the race. 60% odds to win, 40% the odds, and we come up with that the odds are 1.5. And basically the odds of winning the race are 1.5. We put this in the same way that we look at, we look at disease and look at these pieces. And this is what the case control study is basically doing, comparing cases with controls. And we're doing this at a time with somewhat relatively rare events, bringing it forward and looking at the cases as exposed and not exposed, the controls as exposed and not exposed. So if we take this one more piece, what we remember with a case control study, we're not able to determine incidence. So by doing that, we would take incidence, the number of new cases that have come about. Because we do not know the incidence, we're going to start with cases and move backwards and calculate this odds ratio that we've been talking about. Hence, again, we cannot calculate a relative risk from case control. Calculating a relative risk is going to be higher up the evidence pyramid and more likely to be published and more likely to have evidence, but the case control study will calculate odds ratios. So this is the odds ratio that we have. We can calculate this from either a cohort, but we're going to calculate it from a case control study now. And oftentimes the odds ratio can be used instead of the relative risk when we do not able to determine incidence. Again, the odds ratio can be a good estimate, which is what we would use when we look at a case control study. Again, case control study, it's going to be the proportion of the cases that were exposed and the proportion of the controls that were not exposed. If we look at this measure of association, again, it's a simple calculation in one sense, the odds of exposure among the cases over the odds of exposure among the controls. And the question that you're asking here is how much higher is the odds of exposure among the cases as compared to the controls? Kind of in that same way of looking at the horse race. I think you've probably covered this, but we'll do it just again as kind of a reminder. If the odds ratio is 1 or close to close, that's going to say that the cases and controls are very, very similar, and that there really was no association between the exposure and the illness. If the odds ratio is greater than 1, it's going to say the odds of exposure among the cases is higher, and that the exposure could indeed be a risk factor, that what we were looking at can be something that's increasing the risk. Likewise, if we find an odds ratio of less than 1, the odds of exposure among the cases is lower than the controls, and then whatever we're looking at, whatever that exposure is, or whatever that factor is, it could actually be protective because the risks are lower. And the magnitude of the odds ratio, the higher or the extreme lower, is going to show you the strength of that association, either as a risk or as a protection. And I think probably knew that just as kind of a little bit of a reminder that we have. So in the case control study, you cannot calculate the relative risk because we're bringing it through there. So we're not able to do that. We don't know about the incidence. And so therefore, we're going to calculate the odds ratio. Again, looking at the exposure of the disease, again, what are the odds that a case was exposed? What are the odds that the control was exposed? A little bit of repeat what we've just done. The odds of a control having been exposed are, again, a simple type of a calculation that we would see. Let's move into a real example, a published example of a case control study. This one was in environmental epidemiology, and it was looking pretty much at breast cancer risk and exposure to a pesticide. And this was a case control study, as demonstrated, again, to look at the risk of postmenopausal breast cancer associated with a historic pesticide exposure. They had 155 cases recruited or population-based, were cut from a population-based cancer registry, and controls matched there almost 1-to-1, obtained from a tax assessor and Medicare list mailing. So what we're seeing is cases that have breast cancer, and the controls did not have breast cancer, and chief from that other source. As you did the calculations and calculated the odds ratio, you found that breast cancer was 3 times as likely to occur among the women that were exposed to the pesticides. The odds ratio, 3.22, the 95% confidence interval, 1.38 to 7.53. 1 is not in this interval, so we would find ourselves to have a significant odds ratio that we would be concerned about. Now, their conclusion, I think appropriately, was additional research is needed to confirm these findings and to better understand the underlying mechanisms. Remember, we did a case control study, and we needed more evidence. So the case control study is not quite there at the top of that pyramid where we would like to have some additional information. Dr. Weber, if you were reading this paper, would you, this is kind of an interest. I think this would give you, I think you would agree with those conclusions that this is something worthy of further study.
Oh, absolutely, yes. And how you would set up a further study is another question, because we're talking about people who were recruited from different settings and so forth. So this is not going to be any sort of a randomized trial. It's going to have to be some creative design to expand our experience with this and to see if we can find more information about how long the pesticides take, what was the length of exposure of patients, all sorts of details like that. But yes, this is a good starting point, as you point out, but we going to the next step is not as simple as it sounds.
Exactly. And we'll go to
one of the nice things, Dr. Lackland, if you're a clinician, you have a lot of cases. So that's something we have. We start with a lot of cases, and it's nice if you can to start with new onset cases, in other words, incident cases. But you have those, and then you want to create controls that are similar to your cases. And you go backwards in time. You start with the cases and the controls, and you try to go backwards to find out what were the prior exposures. So it has some challenges in getting the right comparisons, and has some challenges in assuring that the information you're getting on the exposure is valid. So those are pretty important challenges, but it can be very useful. And early in my career, I did a very large study in end-stage kidney disease and looked at all new patients with end-stage kidney disease, and then used random digit dialing to get a representative sample from the same population for controls. And we were able to look at a lot of the risk factors for kidney disease in that way.
Yes. These are superb directions. One more study, and this is one looking at strokes, and another example of a case control study, but very importantly, to looking at as what Dr. Weber and Dr. Whelton have been emphasizing, what we're able to interpret from doing an odds ratio and from doing a case control study. In this particular study, they identified 961 patients with first ever strokes, ischemic strokes, at this relatively young population of 25 to 49 years of age. And they matched those, and this was almost this was a more than one control for a case, which is oftentimes done in different studies, matching the people that had not had strokes. And what they were able to do is identify a number of risk factors in this relatively young population, factors that were associated with them having a stroke. And if you think, typically you wouldn't see strokes among 25 to 49-year-olds, yet they still have these. So what are the factors that are associated with this group? And as you can see, and again, this is not necessarily about stroke, but it is an example of an NCD that we would look at. In their case, they found a significant odds ratio for AFib at 10.43, fairly high, 10 times the risk associated with atrial fibrillation for having a stroke. And if we look at the confidence interval, 2.33 to 46.77, kind of wide. And we would all kind of say that might be due to the size of the case control study. It's kind of a wide confidence interval there, but does not include one. So we're looking, this would be a significant risk factor, previous cardiovascular disease. is also a significant risk. Type 2 diabetes, significant risk or odds ratio of 2. LDL cholesterol, significant odds ratio 1. Being a current smoker, also right at 2. Hypertension, our favorite, 1.43, and again, a significant confidence interval, as well as a family history of stroke. What these authors concluded there was that establishing the association between these 11 vascular risk factors and early onset ischemic stroke, among which atrial fibrillation. So what they're saying here is we identified these risk factors. Now we want to ask some other questions, or we want to propose an intervention. What can you do? That's going to take another study. But what we found here was that these risk factors associated with 25 to 49-year-olds, fairly consistent with what you would see in other populations. So perhaps a very good use of a case control study, and something that you'd be able to do in a relatively short period of time. And as Dr. Whelton brought in here, very importantly, but you want to do those other pieces. You want to get that incidence. You want to see the new cases. You want to have something with a little stronger evidence rate. And now we come to our cohort studies, which can be one of two ways. It can be a retrospective cohort study when you have very good records and something that you can rely on. And then there's also the traditional prospective cohort study.
Now, I know that you're correct, Dan. It's really a Harvard thing. They call it retrospective, but I think that's a terrible name because prospective studies are always prospective. They may not be concurrent in time. You may go back to a database, but you are starting with individuals and looking over time for exposure. So the analysis, I think this is really important. The analysis that you have in mind is always going to be prospective. So you can talk about incidence. And in the exact opposite way with case controls, you said it. We have a lot of cases. We have to find the right control group, but we can do it almost instantaneously. And there we are going back in time to try to understand the exposure. So it's truly a retrospective analysis.
Okay. That's a great point. And I think it is we are able to calculate incidence. And so it is a moving forward, going from the disease free to the diseased. Thank you. Thank you, Paul.
Yeah, and I know Harvard has forced us with the terminology of retrospective cohort studies, but I think it's terrible because they're never retrospective. They're always prospective.
Okay.
I would call a retrospective cohort study a non-concurrent cohort study because you're using a testing database. I mean, that's my, I get off the soapbox now. I hate that terminology.
I appreciate it. And it's a very, very valid point. I think it was, my point for everyone is that we have the ones where we're collecting data over time, and we will show those, versus the ones where we're using very good records. And but you have to have those good records. You have to have good, strong, and which we do now. And I think more and more we're getting this. As to however we call it, we can remove we can remove retrospective. But if we look at the two directions and the two components that we have here, the prospective cohort study is very time consuming. It's very expensive. It provides more valid information on the exposure because you're able to actually observe and to follow it through, and it allows you to do measurements on potential confounders as you're moving through in the truest type of sense. The other way, where we're looking at records, that we're looking at already collected records and putting those in some type of chronological order, it's cheaper, it's quicker. It's appropriate again to look at it's appropriate for long latency periods where things that we work with stroke and with cancer, these can be very good, very valuable pieces that you you really would have a struggle with following someone for 30 years, 40 years. Go ahead.
You're right. I mean, with non-concurrent cohort studies, the issue is the quality of the data set. And you can have a fantastic data set that has collected everything and is right there, and it can be way better than anything that can be produced with a prospective, traditional prospective cohort study. And on the other hand, of course, as you said, you can have a data set that is missing a lot of key variables, that not of high quality and not very good. So the key for a non-concurrent study is really what's the quality of the data that underpins the analysis.
Yes. Well, I think
could I ask a question? Because this is something that bothers me sometimes when we get the sort of data you just showed us from the ischemic stroke study, where there were a whole bunch of factors that seem to be associated with it. People with atrial fibrillation were more likely to have it. People with hypertension, people with diabetes, people with a family history, so on and so forth. So you've got all these possible causes, or not necessarily causes, but relationships to the ischemic stroke. And many people will have multiple of these risk factors, right? I mean, many people with diabetes also have hypertension. Not surprising if such a person would get atrial fibrillation as well. Oh, how do you separate out individual causes from what you might call constellations or aggregations of causes? What are the real learnings from those sorts of data? It's complicated, isn't it?
Yeah. Yeah, Michael, I absolutely. And I think that there's your analytical plan. And that's why your original critical question is so very, very important. And what you could get something is very, very similar to what we saw with the stroke study, where we have multiple risk factors were put into the model, and it kind of, in one sense, kind of ranked them. So if you were looking at that particular analysis, you would say AFib is kind of ranking, and then you would look at some others that were these risks significant. And you would have something for each of the risk factors, and you could list them at least for that particular analysis, and then you would identify those that seem to be less associated. And looking at your analytical plan, I think very appropriately. But to your point, if that analytical plan is so important, because if you're only looking at one factor, you can really be misled and miss some very important pieces.
And as you pointed out, you're going to infer causality. You can't prove it. Clinical trial will do that much better. But you can do certain things. You can try to adjust for confounders. You can stratify. So look in the group of diabetics and what's happening in that group. And you can use sort of the theory of causality. Is there a dose-response relationship? Is the temporal sequence right? Those sorts of issues. What is the magnitude of the difference? So you can probe the data, and you can certainly get a lot of useful information. But of course, it's not going to be perfect. And if all the studies line up in the same way, if you have case control studies and cohort studies and multiples that have used different methodology, and they all seem to be giving you the same sort of general answer, that will make you a little more confident in the findings. But that's always a part of careful, biologically driven analysis of the data.
Perfect. Hey, well stated. I think to Dr. Whelton's point, this is the kind of direction that you have, again, moving forward, backwards, looking at that cohort study. And again, where we're looking and being able to find it here, the study population, seeing the exposed and the non-exposed, and then who developed disease and who did not develop disease. And so it's important, again, to be able, you can go in either direction, but it's important that you have the proper data and solid data to be able to do it. As Dr. Whelton said earlier, a key piece, relative risk, what we would like to see is the measure of the strength of the association based on prospective study or on cohort studies, where we're able to determine the number of new cases that people are developing. We're calculating incidence and the development forward. And that's kind of our difference between the relative risk and the odds ratio that we calculated earlier. Again, it's a relative risk, a measure of association for a cohort study. It compares the proportion of persons who were exposed who became ill with the proportion of persons who were not exposed and were not exposed and became ill. So our relative risk, the attack rate among the exposed, the attack rate among the unexposed, it answers the question, how much more likely is it for people who were exposed to become ill or to get the disease than those people who were not? Again, how much more likely is it for people who were exposed to have an incidence of the disease? The ratings are basically the same. If it's 1, there's really not much an association. Greater than 1, it's a risk. Less than 1, it's protective, and basically the magnitude is a value of the association and the amount of the risk. We interpret this in very, very similar manners that we would see to the ratio of the disease incidence, new cases, among the exposed to the disease, the non-exposed. It quantifies the magnitude of the association between exposure and disease. Again, varies between 0 to infinity. And again, greater than 1, there's a risk. Less than 1, kind of a protection. And so that you would interpret that if you had a relative risk of 2, it would be interpreted as a 2-fold increase in risk for the disease. A relative risk of 0.7 would be interpreted as a 30% decrease or a protection against, in one sense, getting the disease or developing the disease. Again, we've spoken about this already, prospective cohort studies, etc. And here's an example of one moving forward. This is, again, labeled in this particular paper as a prospective cohort study. This is looking at risk factors of stroke, very similar to what we have, in this case, looking at people with normal blood pressure. So you can see very large groups. This is a total of 11,228 men and 17,178 women. 45 to 73 years of age, were examined in this population-based cohort study with the incidence of following stroke, and they followed these individuals for a 6-year period. So you're kind of thinking, that's a lot of folks. Yes, but you think about what is, just in general, what's your knowledge about developing stroke with people with normal blood pressures? So kind of relatively lean. So I'm going to need, as Dr. Weber and Dr. Whelton said earlier, I'm going to need a lot of people to see this and to be able to study this. So thinking again about your cohort. So they determined that age had a relative risk of 1.12. There was some 30 years, just about 3 decades of life. Being a current smoker had a relative risk of 3. Body mass index was 1.4. A high diastolic blood pressure, relative risk 2.3. A history of coronary heart disease, relative risk of almost 5, and gastric ulcer, relative risk of 2. Those remain significant in the incidence of having a stroke. The interpretation was in subjects with normal blood pressure, there are a number of potentially modifiable risk factors associated with increased incidence of stroke. So now, if this were my study, which it is not, I would follow up on what Dr. Whelton has suggested I do. Now I'm ready. I've identified some risk factors that I might be able to intervene on. So now my next study would be, can I successfully adjust these, or can effectively affect these risk factors, and will that lower the risk? And I would do that with a clinical trial. Dr. Whelton, is that what you would probably do, Dr. Weber?
Yes, incidentally, Dan, we have a robust discussion here, which is great. That's what scientists do. But you've done a fantastic job describing. And when you look here at the relative risk, this is the best estimate of risk. So that's the number we say this is our best estimate. And of course, as you showed previously, you would then want to say, what confidence do we have in that number? And we usually use some estimation of confidence. The common one would be 95% confidence interval. And it's basically saying if you repeated the study 100 times, the true risk would be somewhere between the lower and the upper number for that confidence interval. So when you're looking at a relative risk of 1.12, you're saying, how much confidence do I have in that? So that's what you typically start with. And then you, of course, explore the data a little further to see, all the other patterns. Are they consistent with a true association that could be causal in nature? And then if you really want to nail down causality, you would probably have to go on to a clinical trial.
Excellent.
There's another issue too that comes up when you look at something like this. There are just two simple questions. First of all, you have age as a risk factor, and as Professor Whelton just pointed out, 1.12. Not sure what you do with that, but it's per 1 year. What would happen if you said per 10 years, because this was a long-term follow-up, or they had 6 years. So why didn't they say per 6 years or per 3 years or something like that to give us perhaps a better sense of the relationship between a stroke and time?
Very, very, very straight. I don't know the answer to that question, but I think that would certainly be something that you would be able to analyze directly. I would, I think it would certainly be greater, and I think it's showing kind of the impact that this is kind of a consistent pattern. So this would say that the 46-year-old has a higher rate than the 45-year-old, and you're assuming that, or I'm assuming that might be consistent throughout the pattern. But I think your point's extremely well taken, because this is 3 decades of decades of life.
And we're talking here about relative risk, and that is a very useful risk indicator when you're looking at associations. As we're looking at here, we're looking at risk factors. And the second question, of course, for any clinician is, okay, if there's an association and I'm confident in it and it looks real, what is the clinical impact of that? Is it important? And that we get from looking at a different risk indicator. We want to look at the absolute risk, or the difference in absolute risk. You'll probably be talking about it later. So relative risk is useful. It has to be really taken in the context of its clinical importance if you're going to use it in a clinical setting. So when we're publishing, we're often asked to provide both pieces of information. What is the relative risk, and what's the absolute meaning of this for the patient and for the clinician?
Excellent. Thank you.
And you can do that, as said, as an absolute risk, a difference in absolute risk, or many times you'll see it presented as a number needed to treat to prevent an outcome. Particularly in clinical trials, you see that, but you also see it in observational data as well.
Excellent. And I'd like to go from an actual study that we just saw, a cohort study we just saw, and then look at a newer type of part where you've got a cohort where truly followed as Dr. Whelton has suggested, a time when they were basically disease-free. This is the Cardia study and that we're involved with, and it just shows you the opportunity that you have. So in phase 1, they've identified a young group of adults and basically followed them, now going into the 40th year of follow-up, and this will be kind of continued all the way through. So you began with individuals in their 25 years of age, followed them throughout time, and to both Dr. Weber and Dr. Whelton's point, you're able to look at factors. In the very beginning, you can look at the different risk levels, any type of beginnings, preclinical findings and stuff. Then as we got into their 40s, after years of follow-up, again, this piece, 20 years of follow-up, you now began to see some moderate risk, some subclinical types of findings that were coming in, big factors with early lifestyle. And now, 40 years later, where we're still finding it, now you're starting to see events occurring. You're starting to see, if you're those that are interested in cognitive function, you're able to look at these types of stuff, and they will be followed again, carrying on there. And at one point, you can follow the risk, but also what were those protective factors that were identified early on that has someone living into their 90s or maybe even into their hundreds. This type of a study, this is what you're doing. And I think to Dr. Whelton's point, granted, this cohort began as a prospective cohort study in 1985 and then followed over time. But now it's become a cohort study in which you have some outstanding records that you could do the things that we're talking about doing. You can calculate the incidence, but in one sense, you're using a database that's already established. And that's what emphasizes, I think, so much with Dr. Whelton's nomenclature points that we were sharing, that this cohort study, you want to say, I have a cohort. And if you have a cohort with good records and good indicators and good follow-up, and you can calculate incidence of disease and calculate relative risk, I think that's a very, very strong piece. So I share this as an example of, now at this point, among many other cohort studies that are out there, cohort studies that you can do and treat and assess, calculating the relative risk of disease. And this is just one simple thing that individuals have looked at, that you're looking at these types of studies. You can look at hypertension and the development, the relative risk of developing hypertension, and you can see what some of the differences are. And you can see in this particular case that what the different ethnic groups kind of develop. But a very important piece of it is that you have this kind of information, and it is brought in from a cohort study that allows you to calculate a relative risk, allows you to look at things like absolute risk, and it has that much more value and implications that you would move forward. We also have, again, we'll fix the nomenclature, but what we would say is the retrospective cohort study. Again, looking at this as a defined group in the same manner that we have, but this does require those accurate records and databases, as Dr. Weber and Dr. Whelton have both indicated. It requires this good piece. In this particular study, this is looking at cancer incidence. So this is a database that allows one to calculate cancer incidence, and therefore would be able to again calculate incidence rates, calculate relative risk. In this case, they were looking at a group of linked hospital discharge records, cancer registries, and death registries. This is kind of a global type of study. And so what this group was doing, they had very good databases that they were able to capture, able to analyze. They were then calculating things like this age-adjusted incidence rate and looking at it in the different countries. And you can see a little bit here. So here in Hungary, the incidence rate's substantially lower than what you saw in Scotland. You're able to look at 1-year survival rates, and again, seeing what the variation is. Looking at this database that you have, this is labeled a retrospective cohort study, but we'll get away from the retrospective aspects, more of into that it's a cohort study that includes good records in which we can calculate incidence. If we wanted to, we could calculate relative risk. And their conclusion from this study was that substantial improvements in the use of international recognized common terminology, standardized data coding, and data completeness for prognostic indicators are required. And so that's what they calculate from this particular study. And this could be the next study. One more. This is, again, another study labeled the retrospective cohort study. This is looking at a predictive model for diabetic retinopathy development. Retinopathy development. I can calculate incidence, and I can carry this forward. And so this retrospective cohort study is conducted in 330 patients. That's the size of the cohort. And they were able to identify risk factors associated with developing incidence diabetic retinopathy, and found the things that we've been talking about. They calculated a hazard ratio here, and looking at age, again, very significant. I'm not sure how they looked at it, Dr. Weber, but it's there. Diabetes duration, hemoglobin A1C, albuminuria, and triglycerides. And the point is, this is not about diabetic retinopathy, but they were able to use this cohort database, calculate these kinds of pieces, and now they're saying combining age, diabetes duration, hemoglobin A1C, albuminuria, triglycerides. This model is effective for early recognition and interventions of individuals at high risk for diabetic retinopathy. I would say we could take this model and perhaps do an intervention with the individuals that were at greater risk of developing diabetic retinopathy. Another use of this type of a database and this kind of feeling. So kind of bringing all this together and kind of in a summary, the ones we've been talking about, if we want to calculate incidence, as we've kind of emphasized here. The numerator for incidence, the new cases developing the disease, the denominator are susceptible people without the disease at the beginning, is going to require you to have a cohort study where you could follow these individuals over time. The prevalence of a disease is all cases at the time of the assessment, all persons examined or assessed, and looking at a cross-sectional type of study will allow you to do this. And so you're thinking about what your capabilities are, what you have, what you don't have. Hitting on one more, the advantages of cohort studies. It allows you to look at incidence, and as Dr. Whelton said, absolute risk, such an important piece. I'm able to calculate that absolute risk from the incidence. It allows me to look at risk of exposures and disease development, exposure without bias if the disease is present. So I'm able to reduce that level of bias. I'm able to look at exposure and multiple disease development, again, very important. And finally, with the advantages of the case control study, I'm able to look at relative risk. The disadvantages, it can be very costly. And if I'm using it in the traditional prospective way, it can be very time consuming. So if I'm taking a disease, let's take many cancers. If I'm looking at something esophageal cancer, I'm looking at kind of a rare cancer, I'm going to have to follow those folks for an extended period of time, I'm going to need a very large, perhaps very impractical amount of the number of subjects that I'm going to be following. Makes it very different. It again is somewhat inefficient, as many subjects will need to be enrolled that will not develop the disease. This is one of the pieces that you have, and you run the risk that they don't develop the disease. You've been following these folks for an extended period of time, and nothing has happened. And only the parameters that are being measured can be assessed. And so if I followed a group for 10, 15 years and something new developed and I didn't have it, it can be quite difficult to be able to measure that assessment later.
Dan, when you're looking at this sort of situation of a relatively uncommon condition, is it legitimate if you're going to do a comparison to enrich your population? In other words, don't follow just a sample of the general population, some of whom, very few of whom are going to get, to use your example, esophageal cancer, but people who in general have certain risk factors that may be more likely to be associated with esophageal cancer, sure. Whether it's that's a legitimate way of, in a sense, reducing the cost and reducing the complexity of these studies.
Yeah, absolutely, Weber, and I think that's very often done, and it's done certainly in cardiovascular disease. That either the people we want to follow maybe have an increased risk of developing or having a stroke or having a heart disease. Dr. Whelton, I know you do a lot of this as well.
Well, I would just say, and you showed a beautiful example from cardia. So you can kind of invert this with the prospective study, the cohort study. If you have existing databases that have high quality and have been carefully done, you can do this, you can do studies rather quickly. And they can be really, really helpful. Early again in my career, I was able to link some trial information, exposures in the Mr. Fit study and HDFP, and link that to the end-stage renal disease database. And so you had very nice, immediate information that was prospective in nature, non-concurrent, but prospective in nature, and allow you to do a prospective analysis at very limited cost, and really, really helpful. So sometimes prospective studies can be done rather quickly, and they can be of high quality, but sometimes you want to do it and you look at the database, and as you point out, they didn't measure a key variable that you wanted, or they didn't have a key variable that would be a confounder. So it's not very good, or it's a no-go situation.
Yep. And I might add, in something like cardia, one of the other advantages, there are some cohort studies that do this. Cardia has stored samples. And so if you found a biomarker today, and Dr. Weber has a great biomarker that he wants to study, there are some reserved blood samples and other types of tissue samples that have been frozen and are available, that he could be able to go and look at these stored samples. But there's not a lot of that, but there is some. So there's this tremendous advantage into the cohort studies. But as we look at it and kind of comparing the cohort studies.
Sorry, one other thing, Dan. As we sort of put on our review editor hats, all three of us do that. We see these days a lot of databases that are made publicly available, particularly coming out of the US and also out of the UK. And so there are a lot of groups that do analysis, non-concurrent, but prospective analysis using these databases. And we got tons of those papers. And a lot of times they're not terribly interesting because all they're doing is repeating what others have already shown. But there are sometimes you get them and you say, wow, this is really interesting. They've taken a novel question, an idea, and they've been able to go to an existing database and do a really careful analysis. And this is really very helpful. So as you pointed out, Cardia and many other studies are available publicly at no cost. You just have to apply for the data. The UK Biobank is another big one in the UK, what's publicly available. And there are other studies around the world as well. So those can be very useful if you have a novel idea and you can do a proper, careful analysis.
Brilliant. Kind of summarizing our strengths, for a cohort study, it's the strengths that we have. We think about it's a rare exposure, not a rare event. It allows you to examine multiple effects on a single exposure. It minimizes bias in the exposure determination, and it allows a direct measurements of the incidence of disease. So important. For a case control study, it's quicker and inexpensive. We are able to do an awful lot and calculate the odds ratio. It's well suited for the evaluation of diseases, as we've discussed, with a long latency period. It's excellent for a rare disease. And so if you were studying something esophageal cancer, as Dr. Weber was bringing out, it might be that the case control study would be the better design if you were looking at people that you were wondering about a particular risk. And it allows you, the case control study allows you to examine multiple etiologic factors that are in a single disease. And so kind of comparing, selecting, making sure that you're kind of looking at the appropriate study design for your particular clinical question. The limitation is almost kind of what we just got through in this other piece. The cohort studies, it's not for rare diseases. You recommend you don't do this in rare diseases because you decrease the likelihood that you're going to find anything. The prospective aspects are expensive and time consuming. The retrospective aspects of it requires those detailed records. You've got that. It requires, again, very, very solid databases. And pretty much the validity can be assessed by the losses to follow-up. So you're following people in a cohort over a period of time. People get tired of it. They stop or they get lost to follow-up. Issues that you have, and then also creates a need for a higher cost. Not case control studies, you don't want to do those not in rare exposures. You cannot calculate the incidence rate from a case control study. And it does include a bit of selection bias and recall bias, which is why the case control study is slower on the evidence pyramid than what we would have than we see with a cohort study. Another question right there that we've kind of followed is, when is that odds ratio then a good estimate of the relative risk? And one way to look is when the cases are representative of the disease population, when the controls are representative of the disease, of the population without the disease, and when the disease being studied occurs at a very low frequency. And we've been saying that it's more of a rare disease. Kind of bringing it in summary, as we've looked at the different studies, the case series that we talked about, the enrollment is basically people with the disease, but just by definition, it's a case series. The analyses, it's really not very much of it in this. You're just kind of reporting if the person was exposed or not exposed, or that we have. There's no measure of association. And if it's really new and you really want to develop just wanting to report something that's a little novel, small number of cases, and you could have it with this particular group. Cohort study is people in a well-defined group who were exposed and not exposed. They could develop the disease or not develop the disease. That's what you're looking. We're able to calculate a relative risk because we can determine incidence. And again, the population at risk, can be identified and understood. Case control study is about people with and without the disease, exposed and not exposed. Now, again, you're calculating the odds ratio, and it's a population at risk is unknown and rare disease that we have. Just summarizing this piece. So, in total summary, the strength of the risk estimates, it increased with the levels of the evidence pyramid that we've seen. Incidence is determined again from cohort studies. The relative risk requires incidence, and the cohort study design. The odds ratio is a measure of association, and it's determined from a case control study, but it could also be controlled from a cohort study. And with that, we will stop, and we can move forward and take some questions. Dr. Whelton, Dr. Weber, any summary statements? Paul, you're on mute, Paul.
I was going to say you did a fantastic job, and I thought it was a really good discussion between the three of us. And I think you hit the nail on the head. If you have a rare disease, that's when a case control study is really helpful. Cohort's not very good in that instance. And the cohort study, if you have existing databases that are really good for answering your question, you're in heaven, because you don't have to do it, and you can answer a question rather quickly. Sadly, for many things, you don't have that, and then you have to slog through trying to get the funding to do the cohort study, hoping you'll live long enough to be able to publish it. And that is, as you say, expensive and challenging. But cohort studies can, if there's an existing high quality database, be done very quickly and give you really good information.
Excellent. Thank you. Okay. I think
I think then we're ready for questions.
I think so. I'm looking at lots of questions, and I might say, if we will address all the questions, if we can get to some today, that's great. But we will address all the questions.
Great. Thank you so much, Professor Lackland, Weber, and Whelton, for this fascinating presentation and for sharing your knowledge about study design and the measures of association. These topics are very important and relevant to all of our work. And we really appreciate all the examples you included and the discussion, lively discussion, to enhance our understanding of the topic. So everyone, please do not forget to type in the question in the Q&A chat box, not in the chat. And in the meantime, we would also appreciate if you could fill out the evaluation form that we just put in the chat. Your feedback is important to us, and we value your suggestions on how we can improve. So thank you for completing the evaluation forms. Before we open the floor for questions, this time we would like to try a few poll questions that we have created.
Okay, so
let's
hi
jump
everyone.
to the first question. Lizzie, if you don't mind opening the poll, and everyone should be able to see the questions on their screen.
Okay, so our first poll is up. The question is, the researchers enrolled 100 patients admitted for ischemic heart disease and 100 age and sex-matched patients in different conditions. So go ahead and take a minute to answer this question, and I'll show our results and our answers in a moment.
In the meantime, I want to acknowledge that as soon as we opened the webinar this morning, we reached our maximum capacity of 1,000 participants, and we've been getting tons of emails about people unable to join the webinar. So we thank everyone who was able to join, and we will make the recording available to all who registered, and we'll look into increasing the maximum capacity for the next webinar.
We are waiting for you to answer the question.
Okay, results are still coming in while we give it a few more seconds.
I am unable to respond. Maybe it's not open to the panel members.
Yes, that's
Yeah,
correct.
that's right.
Okay, okay,
It
just,
says at the bottom, we cannot vote.
oh, yes.
Yeah.
Makes sense.
Okay, I'm going to close the poll out.
It'd be pretty bad if we voted and we got it wrong.
Yeah, no, that's I like the no
We
vote.
would be exposed.
I am not
So-
able to see the results. Are you, Lizzie?
Yeah, I will share the results
Yeah,
right now.
yes,
So the 11% of our participants answered cross-sectional, 71% answered case control, 2% answered randomized controlled trial, and 15% answered retrospective cohort. And the correct answer is case control.
Good job.
Thank you, everyone, for participating. Let's move on to the next question.
Okay, I'm going to switch this up a bit. Okay, so our next question is, what are some examples of non-communicable diseases? And answers are coming in very quickly. Okay, I'll give this about 30 more seconds. Okay, I'm going to end the poll now. Of our answers, we have measles and malaria, heart disease and diabetes, COVID-19 and common cold, cholera and typhoid fever, and the correct answer is heart disease and diabetes. These are both examples of non-communicable diseases.
Okay, now I can see it. Excellent. Good job, everyone.
Oh,
Yeah.
So 96% of you got that correct. Let's move on to the next poll.
yes, please.
What is the primary objective of a case series study design?
Are we getting the answers, Lizzie?
Yeah, results are still coming in. I'll give it about 20 more seconds. All right, let's end the poll here. And our correct answer for this question is to describe the characteristics of a specific group of cases. So it looks like 70% of you got that correct.
Lizzie, may I make a quick comment there?
Mhm.
And again, well done. And but I think I would also maybe just get everybody just kind of thinking that sometimes you will see someone with a case report or a case series, and they get it published and they kind of overinterpret. And you might see a case series where they claim to be testing a hypothesis, or they claim to a relationship, or compare different, or doing that comparison, which they really would struggle to get. Seasoned editors like Dr. Whelton, Dr. Weber wouldn't let that get through. But there are, you will see something published sometimes where someone has overinterpreted a case series or a case report. And I think it's important to understand what you can and cannot do there.
I think the bigger danger too, Dan, is that readers will, if it is published as a well-written paper, readers will overinterpret it and use it and cite it in their own work later on as evidence for something that really hasn't been established.
Thank you.
Okay, thank you.
We have 2 more to go, Lizzie. Is that correct?
About 3 more. So let's move through these quickly. The next poll is, 1 second. Okay. In a case control study, we know the incidence of the outcome in the exposed and non-exposed populations. Is this true or is it false? You have a 50-50 answer.
Just don't guess.
And I'll give this about 30 more seconds. Okay, let's close out this poll. The results are in. And the correct answer is false. It's about 60% of our participants answered correctly. All right, for the sake of time, why don't we end our polls for now and we can move on to Q&A.
Thank you, Lizzie, and thank you everyone for participating in the poll questions. Before we get into all the questions, I just want to address some of the questions that are around the registration, the certificate, and the slides. So everyone, we will share the slides and the recordings of the session to everyone who attends the session. You do not need to sign the attendance sheet. We have a system to track your attendance based on your registration when you join the webinar. So you don't need to share your email to make sure, we will make sure that your attendance is counted based on your registration and when you join the webinar. And we will, if we don't get to answer the questions, which we want for sure, all the questions, we'll make sure to address those in the next session. At the beginning of the session, we'll address your questions and then move on to the topic. All right, so let's, we may just have time for 1 or 2 questions, but so let's get going. So let's see. Let's start from the top. So the first question is about the number of participants in a case series. What is the upper limit for the number of participants in case series?
It's a great question. One certainly depends on the topic, and it depends on the topic and what you're trying to present. So if you saw something that was just bizarre, you know, this is just something that hasn't been reported, you didn't see that in your training, that one case might be that would be fine, and you wouldn't even really want to kind of wait there. But if you saw something, again, what you're writing the case series about is unusual cases, an unusual finding, something that hasn't been published to an extent. So you wouldn't want to, you probably wouldn't do a case series on individuals that were older individuals that had a stroke and they were also hypertensive. You would want to have those somewhat unusual pieces that would also lead into something else, something that just an unusual feeling. Dr. Weber, you've had experiences with case series. What is perhaps your thoughts there?
Well, they are difficult to manage, and frankly, I have not had as much experience. Years ago, I thought that these would be good kinds of studies to do. But in cardiovascular area and renal areas, it's probably more simple to do prospective trials rather than case control studies, because we have so many patients at our disposal and so many events happen so relatively quickly. That perhaps these sorts of trials are not as important, unless, of course, you're looking at rare things. So that would be my feeling. Dr. Whelton's got far more experience than me in these areas.
Yeah.
Well, I think you're all very experienced. I would just say for a case report or a case series, is what you said earlier, Dan. If you see something that's really unusual, think back to the AIDS era, when the first patient started to manifest with this really unusual pattern of disease, and there was a high mortality. That's when case reports and case series were written up, and they were really very valuable, and it led to a lot of additional studies. Early in my career, I wrote up a number of cases looking at drug toxicity as it related to the kidney, and they were helpful. And they were also very helpful to me because that's where I learned my writing skills to start with. But for things that are already well known, you know, it's not terribly useful. None of us as editors are going to be very interested in a Me Too, what we call a Me Too paper. It's already been well established and you're just writing it up for the 57th time. That's not going to get into a journal that's of any value. But they can be very helpful for unusual, new, and rare patterns of exposures.
Thank you. Thank you so much for elaborating on the case series. We might just have time for just one question, so we will take care of the rest of the questions in the next session. So before we wrap up, a quick reminder that our next session is on February 15th, and we will do the part 2 focusing on bias in epidemiological studies. Same time, same place. Please remember to register individually for these sessions, and we would appreciate if you could use the same name and the same email so that it's easier for us to track your attendance. And this is all we have for today. We thank WH Elite faculty. Thank you for this fantastic presentation. And everyone else who participated in today's session, we really appreciate your time and attendance. It might be early morning or late in places wherever you are. So thank you so much for attending, and you have a great rest of the day. Thank you very much. See you next month. Bye-bye.
Bye. Thank you, Dan. Great job, as
Thank you.
always.
Thank you all very, very much.
Great pleasure.